All right. This is a meeting of the Health and Government Operations Committee. We will be following our standard. We welcome the public. We'll be following our standard procedures for this briefing. And we'll now begin with the first witness. Who is that? I don't have my list.
Ben Steffen.
Ben Steffen, thank you.
Yeah, the Maryland Healthcare Commission.
Ben Steffen of the Maryland Healthcare Commission. Thank you.
Okay, good afternoon, Mr. Chairman, members of the committee. My name is David Sharp. I'm here on behalf of our executive director who has a scheduling conflict with another hearing in the Senate. He may join us shortly, but I'm here to present on an update as it relates to the telehealth study from last session, which is House Bill 123 and Senate Bill 3. With that, I'll begin, and if there are questions along the way, I'm happy to take them or defer to the end. I will ask the individual who's moving the slides forward to advance them at the appropriate time. Okay, so we're jumping right into the background. As you know, the General Assembly passed legislation in the 2021 session that requires MHCC to complete a study on the use of telehealth services using audio only and audiovisual technologies. In June of last year, MHCC issued an emergency request for proposal and competitively selected the National Opinion Research Center, or NORC, at the University of Chicago in September. We are on a tight timeline to complete this study. Work as the final report is due to the Senate Finance Committee and the House Health Operations Committee by December 1st of this year. Key recommendations in the report will address coverage of telehealth services and payment levels for telehealth relative to in-person care. Let's go on to the next slide, please. As a reminder, changes to Medicare telehealth policies since April of 2021 have continued. CMS will reimburse for codes that were added to the list of services through the end of calendar year 2023. In addition, private payers bound by new Maryland law continue to reimburse for services that were provided under the public health emergency, and self-insured plans seem to be following suit. Next slide, please. Where are we today? Is that some decline in telehealth use has occurred. However, there remains a strong support in primary care and behavioral health for its use. The two leading national quality measurement and reporting organizations are moving forward to develop telehealth quality metrics. Moreover, we are seeing telehealth vendor consolidation in the market. Next slide, please. So let's talk a little bit about the study components. Key elements of the study are shown on this slide and the next, and I will step through them for you. They include the analysis of the impact of telehealth on disparities in access, take-up rates among different communities and patient populations, and the comparative effectiveness and efficiency of telehealth on in-person visits and the total cost of care, as well as patient outcomes. Study the alignment of telehealth with new models of care that address opportunities to improve patient-centered care and services for which telehealth can substitute for in-person care, and the impact of alternative care delivery models on telehealth utilization, coverage, and reimbursement. Additionally, assess the efficiency and effectiveness of using telehealth in in-person visits, including the impact on different communication technologies on patient health, a survey of healthcare providers, and resources required to sustainably provide telehealth services. Next slide, please. So here on this slide, we are talking about specific aspects related to patient awareness and satisfaction with telehealth through a survey. I'm looking at privacy risks, benefits of telehealth services, and barriers to care and levels of patient engagement addressed by audio only and video technology. We're also going to conduct a review of the appropriateness of telehealth across the continuum of care and the use of telehealth to satisfy network adequacy standards. Next slide, please. So let's talk a little bit about where we are today. Next slide, please. NORC has developed a research framework for the 6 briefing papers that focus on understanding telehealth utilization patterns, optimal integration of telehealth into care models, the impact of telehealth on care quality and patient safety, and the merits and limitations of audiovisual and audio-only technology in different circumstances and for different patient populations. Next slide, please. NORC has finalized the data applications for both commercial and Medicaid claims for the time period of 2018 through 2021 and has developed an analytical plan to review the data. Next slide, please. NORC has developed and pilot tested the questionnaire for each provider category included in the study. In addition, healthcare associations have been provided a flyer to promote the survey to their members. Next slide, please. NORC is screening consumers to identify individuals to participate in virtual interviews with a goal of conducting 80 interviews. Next slide, please. Okay, so let's look ahead a little bit between now and mid-year and what's the work that still needs to be accomplished. This slide includes just key study activities. These tasks include administering the telehealth survey, completing consumer interviews, drafting the telehealth research briefing papers, and conducting the claims analysis. Next slide, please. A web page featuring updates about telehealth have been added to the MHCC website. We also notified around 100 stakeholders about the availability of this information and let stakeholders know they can subscribe to receive information updates electronically. Members of the committee, this concludes my presentation, and I'm happy to address any questions.
Are there any questions from the members of the committee? So you will be having you expect, as you said in the outset, by June? When do you expect to have your study back to us, completed study?
So great question. Thank you, Delegate. The study results are due to you all by December 1st of this year.
Thank you. Delegate Cullison, followed by Delegate Hill.
Thank you, Mr. Chair. And thank you, David, for this really comprehensive and concise report. Just a question. 80 consumers seems like a small number to me. I mean, I know this is a renowned study group, but that's a very small number. That you're confident that's based on that'll give us statistical information, enough statistical information? Yes,
Delegate Cullison, that will be statistically significant. We worked with the contractor to make sure that the areas that they survey have representation for the categories of the population and that the findings could be statistically valid.
Okay. All right. Great. Thank you.
Delegate Hill.
Thank you very much. And thank you. I'm very pleased that there's going to be a hard push on looking at the quality and outcomes. My question is the question I'm getting from my constituents. I want to know if we're going to be able to get at that too. And that is that people have gotten more used to the idea that they can see a treating physician and then, go to campus, move to another location, go on vacation and continue that relationship. They would do that during the pandemic. What I'm getting complaints of are people who have established relationships with often a talk therapist, a behavioral health therapist, but also with a somatic physician or caregiver, who, because they move out of state, we have laws that prohibit them from continuing that relationship. Will this study in any way shed some light as to whether our statutes and regulations may be out of touch with the reality of how medicine is expected to be practiced by our constituents and by providers? Will it get at that at all?
Dr. Hill, Delegate Hill, the answer is in a roundabout way, yes, because what the study is looking at is to some extent the historical landscape and what's the landscape of the future. And I think what you're saying is what consumers often are saying is that the public health emergency has changed the dynamics around caregiving and has made it much more of a mobile environment. And there's little interest in going back to turning the hands of time back to where we were before the public health emergency. So it is the expectation that the contractor will bring to light in the briefing papers what's the evolution and the future of telehealth.
Thank you.
Delegate Bhandari.
Yeah, thank you, Mr. Chair. To follow with Delegate Collison's question, what is the rationale to have that small pool of survey participant? You said just 80 people participated. What was the rationale?
So the idea, there's a few elements in play. One is that if you're able to get a statistically valid sample and the sample size is smaller, what you're able to do is do it for less money. And part of this is we had to balance the costs that because of the budget, MHCC is using existing operational funds to support that work. And there are many aspects to the study. So once we have achieved what one would refer to as statistical significance, adding more individuals to the pool wouldn't really change the outcomes. They would be consistent whether you added 20 more or 200 more. And so that was part of the balancing decision factors that were here included in this work.
Thank you.
Okay, seeing no other questions, we will proceed to the panel from the Maryland Department of Health. Heather Scheck, Director.
Can other people hear Delegate Rosenberg? Can you
I was
turn up
speaking
your volume button
Oh, okay,
maybe?
I'll turn it up to the top. Sorry.
Thank you.
Can you hear
Oh.
me better now?
Eh.
Next panel is from the Maryland Department of Health. Heather Scheck, Director of the Office of Governmental Affairs, and available for questions, Dr. Aaliyah Jones and Trisha Roddy.
Thank you, Delegate Rosenberg. Good afternoon to you, Chairman Pendergrass, Vice Chair Pena-Melnick, and committee members. As Delegate Rosenberg said, my name is Heather Scheck. I am the Director of Governmental Affairs at the Department of Health. Thank you very much for the opportunity to come before your committee to provide an update on telehealth services as they relate to the department. I am joined by my colleagues, Dr. Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration, and Trish Roddy, Deputy Medicaid Director. And as Delegate Rosenberg stated, they are available for any questions the committee may have. So as you may recall, in August of last year, my colleagues briefed this committee on the categories of behavioral health services that were continuing with a telehealth component after the end of the state of emergency, as well as those that were not clinically appropriate for telehealth and required in-person services in order to best serve the clinical needs of the patient. And since that time, initial data from 2021 shows that the transition to telehealth did not significantly impact consumers' access to care or treatment outcomes. In January through October of 21, there was a 10% decrease from the previous year of individuals who utilized PRP services. There was also a 2% increase of individuals who used residential substance use disorder services. Within that time, there were also a decrease by 24% of inpatient hospitalizations for individuals with behavioral health conditions, and emergency department visits decreased by 25%. And so since the end of the state of emergency, the department has continued to monitor COVID-19 data, positivity rates across the state, and make clinical decisions as appropriate based on that data. So in response to rising cases and the threat posed by the Omicron variant on both participants and staff, on December 22nd of 2021, a provider alert was issued advising that the Behavioral Health Administration was temporarily reinstating telehealth for certain services. And that included the PRP services, including groups, and the substance use disorder residential treatment services that were provided for more than 50% of the time. And that's still currently going on now. And in accordance with Senate Bill 3, the department continues to reimburse for other services, in addition to the behavioral health services that are clinically appropriate to be delivered by telehealth. Some of those services include participant and family consultations, case management services, including application assistance, plan of care, plan of service, treatment plan development. We continue to reimburse for telehealth services for personal assistance, individual supports, staff training and supervision, care provider team meetings, risk assessments. I could go on, but the department does continue to reimburse for those clinically appropriate services. And we also issued provider transmittals advising of the same so that providers were well aware. And I think with that, I'll stop there. It's kind of been status quo for the department. We continue to reimburse for telehealth services. Dr. Jones and her team at the Behavioral Health Administration continue to make adjustments as appropriate in response to the ongoing pandemic. And so, as I said, I will stop there, and we are happy to take any questions.
Are there any questions? Delegate Hill.
Yeah, really quick. Thank you very much. Dr. Jones, it's sort of the question I had before. My understanding from providers in the state is that they're still being prohibited from continuing their established relationships when the person leaves the state, and from patients in the state that they can't continue their relationships with providers. They have established relationships from outside because of our licensing rules. Is that still the case even under the pandemic? And do you have an opinion about whether this is really serving the public interest?
Good afternoon, Delegate Hill. Thank you for your question. Always great questions that you ask. So with regards to seeing providers across state lines, my understanding is that we do have the interstate compact that we're looking for states to join so that providers can continue to see patients across state lines. I think as a practitioner, obviously the less interruptions there are to someone's care in terms of who it is that's providing the care is obviously what's in their best interest. I believe that one of the ways that we're trying to address that as a state is through the interstate compacts. And however, I do not believe that since the public health emergency, and I'm probably saying that part wrong, Heather can correct me, in terms of what orders we're operating under at this moment, I do not believe that they reinstate any overstate, cross-state treatment provider relationships like we had earlier in the pandemic. But I think that hopefully the study that the MHCC is putting forward and also states joining this interstate compact legislation that was passed, that we will get closer to being able to allow people to continue to see their providers over when they're traveling.
Thank you.
Delegate Collison.
Thank you, Mr. Chair. And I'm not sure if this is for Dr. Jones or Ms. Scheck, but I'm not understanding quite the timeline of the data. And I think this is for you, Heather, that you gave us, because I'm wondering, like, from August to December. I think that's the data you gave us, but I wasn't sure that it was limited to that time frame in terms of not seeing any impact in the changes that were made. But then I want to ask the question, were there consumer surveys? Did you check with patients in terms of changing in those settings, the access, the point of access for care? Or were these just numbers of, more hard data in terms of number of patients doing telehealth, number of patients not doing telehealth? I think you get what I'm asking.
Sure. Thank you for that, Delegate. Yeah, so the data that I provided was based off to your point, the hard numbers, the claims that were submitted. We were able to pull those, the type of service that's rendered. So, and Dr. Jones can correct me if I'm wrong, but I don't believe there were consumer surveys done or any outreach to the end user, if you will, the patient.
However, thank you for that, Heather. We have done provider surveys throughout the course of the pandemic. We've done, I think, 3 or 4. I think actually we might have just done our 4th survey to hear directly from those who are providing services about how people are experiencing telehealth. And that predominantly has been positive. And the providers themselves have noted an increased ability for people to be adherent to appointments with fewer barriers to care. So we definitely have seen that. BHA just recently completed a consumer survey. However, the results for that have not been compiled at this time. I imagine within the coming months we should have that data and could present that to you in terms of people's experiences with services during this time.
That would be very helpful. Thank you. Thank you both.
Okay. Seeing no further questions for this panel, we'll proceed to the next panel, which is physician and hospital providers. Steve Wise, Brian Frazee, Brian Hasselfeld, Jennifer Crockett. We are ready for your testimony.
Thank you, Delegate Rosenberg and members of HGO. My name is Steve Wise. I'm here today on behalf of MedChi and the Maryland Academy of Family Physicians. Since I'm the first representative of provider groups to speak, I think it'd be a good use of your time just to sort of refresh your memory on the principal concerns we had with this legislation when it passed. And those are really threefold. Number one, payment parity for telehealth, which was a part of the legislation you passed last year. The inclusion of audio-only calls as telehealth, which was part of the bill you passed last year, and remote patient monitoring. And I'm going to just touch quickly on the last two. The audio-only, as discussed last year, while not a large part of telehealth visits, remains a very important part of telehealth because it is most prevalent in underserved communities and places where there is a digital divide or not access to internet. And for those folks who use it, it is their only means of telehealth. So that has turned out to be as important as we thought it would be last year, even though it constitutes a smaller percentage of telehealth visits. Remote patient monitoring is considered really what a lot of physicians seem to think will be an aspect of this that continues to grow going forward. This is the ability to monitor patient metrics for things like diabetes and other chronic diseases where you can continue to collect data, see trends with a patient and make adjustments in care accordingly. And that the technology behind that is improving and becoming more prevalent. And as we go forward, a lot of the articles you read will say that providers think that will be an even bigger part of telehealth in the years ahead. The final point I'll make has to do with licensure, Delegate Hill's question. The general rule in telehealth is the provider has to be licensed in the jurisdiction where the patient resides. So if you have a patient in Maryland before telehealth, you had to see a Maryland physician. Now, if let's say you have a patient in Maryland, but the provider is from out of state, if there are no emergency orders in place, that provider needs to be licensed in the state of Maryland. And I understand that that causes problems at times among existing patient-provider relationships. Because I know you have other legislation coming on this subject, I will mention to you to keep in mind that licensure is how the state obtains the ability to discipline a provider when there's a bad outcome. So we tend to think of, hey, this is great. I can see my provider and stay in touch. And let's hope that's 99% of cases. But in the one case where there's a bad outcome and the state doesn't have a way to impose discipline or reach that provider, it's a problem. So that's why we have maintained the position that licensure should be a part of telehealth. And you'll notice yesterday we were in support of the compact, which has been a very important tool in that regard. So with that, I thank you very much. I'm happy to answer any questions.
Mr. Frazee.
Great. Good afternoon, Mr. Chairman, Madam Chair, members of the committee. My name is Brian Frazee, and I'm the Vice President of Government Affairs for the Maryland Hospital Association. Maryland hospitals appreciate Vice Chair Pena-Melnick's sponsorship of MHA's Preserve Telehealth Access Act last year, as well as this committee's support of that bill. For all of the reasons that Mr. Wise has already mentioned, we believe that it was one of the most important and meaningful bills that this legislature passed last session. So we thank you all again for your leadership and support. I'd like to introduce our two expert panelists who will speak to the benefits that we are already seeing as a result of the bill. First, we have Dr. Brian Hasselfeld, who serves as the Medical Director of Digital Health and Telemedicine in the Johns Hopkins Office of Physicians, and who is a primary care physician with the Johns Hopkins Community Physicians. And finally, we have Dr. Jennifer Crockett, who is the Director of the Telehealth Department and Director of the Behavioral Health Program for Military Families at the Kennedy Krieger Institute. So without further ado, I'd like to turn it over to Dr. Hasselfeld.
Great. Thank you so much, Brian. Good afternoon, Chair Pendergrass, Vice Chair Pena-Melnick, Delegate Rosenberg, and members of the committee. Thank you for this opportunity to review the impact of this very important legislation. As mentioned, I'm our Medical Director for Digital Health and Telemedicine at Johns Hopkins Medicine, where I oversee all telemedicine, technical, operational, and clinical deployment across our entire delivery system. And I'm sitting here in clinic today, ready to see patients in a little over an hour, which will include telehealth care today, and practice pediatric and internal medicine primary care here in Baltimore City, seeing patients of all ages. And I personally appreciated the flexibility that this important act has provided to us as providers. Over the course of the last year, I've been proud to hold up the work of this legislature, this committee, and this state in local, regional, and national talks as an example of forward-thinking approach to put patients and patients' access first. 2 years into the pandemic, the broader healthcare system has now built and invested in operational infrastructure to expand virtual care access across all specialties and geographic areas. Unlike the patchwork of emergency orders and temporary policies that have existed and continue to exist outside of Maryland, the Preserve Telehealth Access Act has provided longer-term visibility and certainty around specific areas of telehealth as a care option for our patients and our healthcare workforce. Here on our first slide, you'll see that since the pandemic began, Johns Hopkins Medicine has completed over 1.25 million outpatient telemedicine visits to over 375,000 unique patients, predominantly in Maryland, including 250,000 visits to 45,000 unique Medicaid beneficiaries. This care has been distributed across all departments. On the next slide, this care is not simply isolated to one specific type of clinical care. In addition to expected strong and continued demand for telehealth and mental health, our Department of Psychiatry, seen here on the left, and areas of primary care inside of departments of medicine and pediatrics, we've had some of our highest relative use of telehealth in advanced specialty including genetics, neurology, and neurosurgery, seen here on the left-hand side of our graph, showing percent telehealth as a percent of total ambulatory care, which each of these areas in genetics, neurology, and neurosurgery completed over a third of their outpatient care in calendar year 2021 virtually, highlighting the breadth of care and complexity of care that can be appropriately delivered via telehealth to our patients, members, and beneficiaries, and adds to the importance of and our support of payment parity across clinical specialties. The importance of audio-only coverage cannot be understated. Audio-only care has remained 14 to 15% of our monthly telehealth volume. But as we see on our next slide, this audio-only care has not been distributed equally. Sorry, if we could skip one slide forward. Patients insured by Medicaid continue to use telehealth continue to use audio only about 27% of their time during telehealth visits, compared to 8% for patients commercially insured. On the next slide, we'll see while telehealth and audio only access is often framed as a rural issue, areas in both rural and urban Maryland alike have had high rates of audio only use. Audio only as a percent of total care seen in orange and red, where higher rates are used. We see patients in Baltimore City relying heavily on audio only care. Clinicians and researchers across Johns Hopkins, including our schools of medicine and nursing, have been engaging in pilot programs to deliver tools with internet access to patient populations to overcome basic infrastructure inequities related to broadband internet access. But significant collaborative work remains, and we believe access to audio-only care will be an important health equity tool for many years to come. 2 slides prior, and I apologize for the ordering here, we see that our patients are showing strong satisfaction with their use of telehealth. In the last 12 months, we've received over 50,000 surveys from our patients, rating their interactions with their providers 94 out of 100, extremely high. When we go directly to our patients to ask further targeted questions about telehealth going forward, to a group of 2,000 patients who have accessed Johns Hopkins Medicine care, and with over 670 responses, 9 out of 10 would recommend that experience to their friends and family. And 88% responded they would be moderately to extremely important to have access to video visit options beyond the pandemic. In summary, we believe the Preserve Telehealth Access Act is an important patient-centered step in ensuring improved long-term healthcare access for our patients. And we look forward to supporting the ongoing evaluation of audio-only component of the Act. In addition, and though separate from the Act, as already highlighted by Delegate Cullison, we would strongly support regional and national work to eliminate barriers created by the state licensure processes in connecting patients and providers. And we thank you again for this opportunity to speak with the committee.
Does that conclude the Hopkins presentation?
It
In this
does.
panel, there's another witness.
Happy to answer any questions or defer to later at the direction of the panel.
Thank you. Delegate Lewis.
Thank you, Mr. Chair. Thank you to all of the panelists. I'm curious, and I think this question would be for the good doctor from Hopkins, Dr. Hasselfeld. How do you explain the decline in telehealth visits over the last 3 quarters? And I think that last graph that you showed. And do you expect that falling off, that declining trend to continue or level off? Because it begs the question, what's the sustainability? What's the trend for future demand of telehealth if it's declining so precipitously?
Appreciate the question. In that graph, we did see a meaningful decline from March, April, and May of 2020, the beginning of the pandemic. But recall, prior to the pandemic, we were completing about 50 to 80 visits in total per month. And for each of the last 6 months of calendar 2021, for 6 months straight, that number was 33 to 35,000, stable and unchanged with a slight increase in December as the Omicron surge returned, a state of emergency to our region. So while 35,000 is not 100,000, it is meaningfully increased from our 50 to 80 visits prior to the pandemic, and represents about a fifth of our total ambulatory care outside of lab and COVID-related visits across our institution. So we believe that's a meaningful portion of our ambulatory care and is sustained and continued demand over the last 6 months of calendar 2021.
Thank you. Thank you, Mr. Chair.
Chair, seeing no other questions.
Mr. Chairman, I apologize. I did want to let you know we did have one more panelist, actually, Dr. Crockett,
Okay.
on this panel.
Wasn't on the list. That's fine. I've just been advised by staff he should have been on the list. So, Dr. Crockett.
Yes, thank you. So I will try not to be duplicative of what Dr. Hasselfeld said, but a lot of the same, right? So, but I'll try to focus specifically on what's different about Kennedy Krieger and our patient population. So really appreciate the opportunity to share the activities, the telehealth activities that we've been able to do since this important legislation became effective, and to give our perspective on how meaningful it has been for our pediatric patients with developmental and behavioral health needs. So next slide, please. So this legislation has allowed us to deliver patient-centered care by meeting the needs and honoring the preferences of our patients and caregivers. Telehealth is reducing disparities by increasing services to families in Western Maryland, on the Eastern Shore, in Southern Maryland, who would not otherwise been able to access care. Telehealth is also improving health equity by giving everyone the opportunity to get the care that they deserve. Of course, telehealth has also helped highlight some of the inequities that exist. These include access to devices and connectivity, as already mentioned, familiarity with technology, as well as private space in order to do telehealth. So by highlighting those inequities, it's given us the opportunity to address those. We were very fortunate early on to receive some support from the FCC so that we were able to actually get devices to families. So that helped, I think, a lot with our ability to provide primarily video-based services. Certainly see the need for audio only. I just think it wasn't as relevant for us because we had that opportunity to distribute devices to people. This legislation has also given us the opportunity to begin evaluating telehealth in terms of patient and provider satisfaction, utilization across our disciplines, as well as effectiveness. So we'll take the next slide, please. So taking a closer look at the utilization across departments, this graph shows 4 points in time, our telehealth visits during 4 points. The first 2 points were really during that initial state of the emergency, where we were providing upwards of 5,000 telehealth visits a week. The latter two, which are going to be the beginning of the Preserve Telehealth Access Act and then current, we're about 28 to 3,200 telehealth visits a week. So early on, that was 80% of what we were providing outpatient. And now we're about 50 to 65% of the services that we're providing in an outpatient setting are telehealth services. So close to 65% of our current telehealth sessions are behavioral health in nature, represented by that top line in red. And although lower in volume, our therapies, medicine, and multidisciplinary groups are still continuing to use telehealth as an alternative source or alternative service delivery model. So what this graph does not show is the week-to-week or the month-to-month changes that we can see as the result of surges. So telehealth is actually allowing us to be responsive to that and to adjust how we provide care during these surges to ensure that we are keeping our patients and our staff members safe. This is particularly crucial for our medically complex high risk patients. Next, please. So we are finding favorable satisfaction, and within our behavioral health programs, we are seeing comparable outcomes to in-person services. We're also seeing positive effects as it relates to show rates with telehealth versus in-person. But for time, I'm going to move on to the next slide, please. So with the continuation of the Preserve Telehealth Access Act, we know that we will be able to adjust our delivery model in response to surges if we're continuing to face those. We know that we'll be able to reach families who otherwise would not have access to care or who would face significant burdens in accessing care. We know telehealth is not for everyone, and we know it's not for every need, but the Preserve Telehealth Access Act will allow us to determine the situations where telehealth is indicated and to look at clinical and cost effectiveness. It's also allowing us to determine the most appropriate way that we at Kennedy Krieger can augment and improve the quality of our clinical programs. So my final slide provides some of our published telehealth work so far, and we look forward to continuing to determine and disseminate best practices with respect to telehealth with our unique patient population. And I'll take questions. Thank you.
Delegate Lewis.
Thank you, Mr. Chair. Full of questions today. Something that occurs to me is the question of Marylanders who aren't able to access telehealth. And the statistics we've seen today obviously refer to patients who are benefiting from and receiving telehealth services. But we know that because of the digital divide in Maryland, which affects some communities more profoundly than others, some folks are getting left out of this, the digital health revolution, and they're often folks who need it most. I'm just wondering what we've learned in the last 2 years to help us understand access for people who have difficulty, reaching telehealth services, how that's changing. What do we know? And whoever's best positioned to answer that question. Thank you. Maybe no one.
Happy to briefly weigh in, and it's a critical and important question. We feel that some of, and as a provider individually with my patients, seeing it in real time, that some of the potential benefits of telehealth disproportionately benefit patients and Marylanders who have fewer resources. So the ability to eliminate the need to identify transportation, costs of transportation, parking, time away from work, time away from childcare, those benefits disproportionately benefit those who have limited resources. And we view it as an important tool in addressing that aspect of health equity. The digital divide is the balancing component to that, and is an important one. We do believe, and I believe as a provider, that specific benefits of telehealth can be delivered through audio only as a temporary measure to capture some of that value for our patients and citizens while we work on the important infrastructure needs of broadband internet access and digital literacy more broadly across our city, state, and region. So I think that the point is spot on, accurate, and an important one to focus on, and will require both short-term and longer-term measures for those of us that care for patients across our state.
Absolutely.
Thank you.
Yeah, absolutely.
Oh,
Agree.
Are we allowed to have follow-up remarks? Because I'd love to hear from Dr. Crockett as well, Mr. Chair. If that's okay with you, Mr. Chair. We can't hear you, but you're nodding.
Delegate Crockett, very briefly, please.
Thank you. That's quite all right. I think the only thing to add to Brian's comments is we've had the opportunity to be able to work with patients, not just in terms of getting the technology and the devices and the connectivity, but also that knowledge and that familiarity with technology. So we know that was a big barrier early on as well. So that's something that we're looking forward to continuing to improve as we go forward. Thanks.
Thank you. Delegate Bhandari, followed by Delegate Krebs.
Thank you, Mr. Chair. First of all, I would like to thank you, Brian Frazee, for helping our constituents in so many matters. And this question is, I know this is an emerging healthcare delivery model. I know there are a lot of challenges. Last year, we discussed a lot about reimbursement and compliance standard. Dr. Hasselfeld, do you want to touch upon that? And we were talking about cost cutting as well. One of the most well-researched advantages of telehealth. Can you briefly touch upon that reimbursement and compliance standard issues?
Sure. I think in many ways, some of the compliance aspects of telehealth are the most robust, at least speaking internally, as in any other type of care delivery, because it was designed from scratch in light of modern technology and modern care delivery pathways. There is perhaps more compliance investment given the newness of telehealth delivery and the acknowledgement that telehealth care delivery must feel and be as private and as compliant as any other care delivery modality. So just personally inside of our own institution and our own experience, I think that has been an absolute priority, not because it's required, which it is, but because it's so important to patients to ensure that we're getting this right. I will say that as a provider, I continue to view telehealth as a clinical tool. The same way that choosing to send a patient to urgent care, the emergency room, coming into my clinic, or seeing virtually is a clinical choice that is chosen based on the clinical appropriateness of the chief complaint, the patient, and the severity of the patient in front of me. And when we think of telehealth as a clinical tool, we should continue to advocate for giving providers and patients all of the tools available to meet the needs of that unique, intimate patient-provider pairing. And I certainly have been appreciative of the opportunity to have that tool in my toolkit over the last 2 years.
Thank you. Delegate Krebs.
Thank you, Mr. Chair. And a question for Brian, and you sort of cleared up with your last answer, but I was speaking to someone about telehealth the other day, and they said they had a visit and they had some type of a lump in their throat that you can't always see. I forget what it was. They were meeting with an endocrinologist, and they said, open your mouth and let me look in. So there's no way you can look in, you have to feel it. And they were questioning whether or not she should have had a real visit versus a telehealth visit. So my question to you, and you talked about it, it's a clinical tool and a choice. Is there any data that's broken down by provider type? For example, behavioral health versus cardiology. I mean, how do you make sure that on some of these visits, how do we make sure that we're getting the right outcomes and they're really getting a thorough check of what their issue is? And is there any data broken down by different provider types?
Appreciate the question, Delegate Krebs. I think there's a lot. The short answer is a lot more work to be done to ensure we're addressing that very real and appropriate concern. I would say we live in that world as providers prior to the pandemic, right? We live in a world where our patients have walked into an urgent care site or an emergency room, the quote unquote higher cost of care venue, but it was what was more easily convenient and accessible to them, the patient. Is that quote wrong from my perspective as a provider? Sure, but it was what was right for the patient to figure out the next step in their patient care journey. And we've lived in that world forever in healthcare. And that same issue will apply to telehealth, but for every patient that ends up in that specific scenario, there will be the patient that saved childcare, time away from work, travel, and transportation costs to be more appropriately cared for virtually than forcing them to come down into a clinic if that's the choice that they made. And so I do think we'll have trade-offs on both sides, but more work to be done to better deeply understand that across the clinical care disciplines.
No, thank you. And I appreciate all this has been a huge success. I just want to make sure that we drill down on all the modalities, but it sounds like you are. Thank you so much.
Absolutely.
Yes, we can't get back to the thing. Are there any other questions? Well, there are no more questions from committee members, so we'll proceed to the next panel, which is of behavioral health providers, Ann Seacott, Kim Wireman, and Lori Doyle. In whatever order you wish to proceed.
Thank you, Mr. Chair. Thank you very much to the committee for the opportunity to speak. My name is Ann Seacott, and I'm here today on behalf of the Maryland Addictions Directors Council. We're very grateful for the General Assembly's work last year to pass the Preserve Telehealth Access Act. I'd like to take this opportunity to raise one concern about the Maryland Healthcare Commission's study, and that's the absence of community-based behavioral health programs in the survey. Various behavioral health organizations have communicated with the Commission about the need to include programs, not just individual practitioners, in that survey. When the results of the survey are released, there could be important information missing specific to the public behavioral health system. And we certainly hope that information gathered by the Behavioral Health Administration that Dr. Jones talked about will be able to be considered as part of that information. This panel today is here in follow-up to a hearing you may recall from the summer. When the public health emergency was lifted, we had believed that the telehealth allowances would continue as per the Preserve Telehealth Access Act. The Behavioral Health Administration issued guidance limiting the amount of use of telehealth in two specific settings: residential substance use disorder programs and psychiatric rehab programs. We were not convinced of the rationale for this decision, nor did we think the department had the authority to set these limitations. The limitations went into effect nonetheless, and today both Kim Wireman from MADSI and Lori Doyle from CBH will be speaking to this.
Proceed.
Kim,
Hi,
you
Mr.
there?
Chairman, I'll jump in if Kim is not ready.
Please proceed.
Thank you, Mr. Chairman. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. You should have our written testimony. There it is up on the screen. Thank you. So we have surveyed our 90 member organizations about telehealth and the experience of the individuals we serve, both kids and adults. Before I get to that, let me just acknowledge the department and thank them for lifting the prohibition that Ms. Seacott just referred to in light of the Omicron surge. And so we hope that the department will see fit to lift that prohibition through the remainder of the study period for HB 123, because it's an important component of what we do, psychiatric rehab services. So back to our survey results, what we found is pretty consistent with what you've heard. 70% of respondents would use telehealth for half or more of their visits moving forward, and 75% reported the same or better therapeutic connection using telehealth. And there are various reasons why our clients prefer telehealth. You've heard some of them: transportation, childcare. There are some populations, individuals with developmental disabilities, who find our waiting rooms sometimes busy and chaotic and would prefer to use a telehealth situation. Just fear of COVID is a big reason why people stay away. So that said, there have been some challenges with the use of telehealth. You've heard about the broadband challenges, and that's where the audio only has really been a godsend. It's also been a godsend for our older population, some of whom are not as conversant with the use of video technology and feel better using an audio only format. The other area where there are some challenges is with the kids. So, kids have had that virtual learning schools for a while and are using Zoom and other platforms and are zoomed out. And I think we can probably all relate to that to some degree. So the kids or the parents might say, we don't want to do a video clinic appointment because we're just zoomed out. And if they miss the clinic appointment, that could also curtail their access to other services that are they're required to show active clinical treatment to get into, like psych rehab services. So there are some challenges, but by and large, it's very well received by both clients and staff. There are a few recommendations that I'd like to talk about from the behavioral health perspective before I close. The first one Ms. Seacott just touched on, and that's the Healthcare Commission study. The way that they're looking at the study is really focusing on individual clinical practitioners, licensed individuals. The great majority of what we do are services that are rendered by paraprofessionals, so psychiatric rehabilitation, crisis beds, assertive community treatment, residential housing programs, supported employment. These are all services that keep this population at the high end, the individuals who use the ED and the inpatient care more often than the average population, out of those high cost settings. So it is critical that the Healthcare Commission take a look at these services, and we are more than happy to help them with that survey and getting to the kind of providers that they need to talk to. The other concern is something that Mr. Wise raised, and that's around remote patient monitoring. The uncodified language direct the department to consider the utilization of RPM for behavioral health and somatic care. We have serious workforce shortages. They existed before the pandemic. They are worse now. I have spoken with this committee and others about some technology we're using that's medication adherence technology, and allows our organizations to focus their staff time more effectively. The clients we serve love it. The staff love it. It eliminates, all of it eliminates med errors. So it's really a win-win-win. And I'm sure there's other kinds of technology out there available for behavioral health and somatic care. We haven't seen much movement on this. And so we hope that we don't lose this opportunity to try some things that can really help us extend our workforce. We're going to need that moving forward. So with that, I will close, and I thank you for your time.
Okay, is the third member of the panel? Yes, Kim, I see you. Please proceed.
Thank you.
Thank you.
Excuse my technical difficulties. I'm Kim Weyerman. I'm here representing
I
Maryland
can't
Addictions
fault anyone
Directors
for their
Council.
technical difficulties.
Yeah.
Go ahead.
Thank you. Thank you. I'm here representing Maryland Addictions Directors Council. MATSI represents SUD and dual recovery providers across the state and delivers over 1,000 residential treatment beds in Maryland. We're here to testify in support of unlimited telehealth under the Preserve Telehealth Act. In order to avoid the alphabet soup of treatment and to give you our feedback on the implementation of telehealth, I'd just like to address two separate care levels. One is residential and the other is outpatient on the addictions treatment side. First, residential. As the committee may know, SUD residential was restricted to 50% telehealth use. As an unintended consequence of that regulation, providers are really only able to use telehealth in SUD residential in very supplemental and limited ways. That's because providers, both large and small, don't have the internal ability to track individual clients' use of telehealth for 300, 100, or 40 clients. We just simply don't have the way to do that. Moreover, if a client exceeds the 50% limit, the provider may lose billing for the entire week for that client, not just for the day in which the excess happens. We continue to advocate for unlimited telehealth for SUD residential treatment, but let me make it clear that that does not mean that 100% of the treatment will be delivered via telehealth. It simply means that we'll remove that 50% restriction that limits us in unintended ways from really using it in a robust fashion, as we did during the state of emergency. Also, to be clear, residential clients receive treatment in residential settings with the same comar billing and service quality requirements as face-to-face treatment. In short, there's no difference in comar restrictions or regulations between telehealth service delivery and face-to-face service delivery. Next, let me turn to SUD outpatient. BHA allowed unlimited telehealth for SUD outpatient care levels. MATSI providers are reporting that telehealth has a very positive impact on client retention, client completion, with increased client rosters in some agencies across the state of as much as 15 to 20%. Surveyed clients continue to report 80 to 85% rates of satisfaction to high satisfaction with telehealth treatment. That includes both outpatient and residential clients. MATSI providers have not seen increased client complaints or regulatory issues. Clinicians and counselors remain supportive of telehealth treatment. Importantly, outpatient care using unlimited telehealth can be combined with a state-funded bed to deliver very effective treatment that's directly comparable to those SUD residential care levels that have a 50% limit. We're asking, MATSI supports unlimited telehealth across the continuum in both outpatient and residential care, and we're asking for the continuance of 100% telehealth or unlimited telehealth in residential. I'd also like to say thank you to MDH and BHA for re-implementing unlimited telehealth in the face of the Omicron spike. Lastly, MATSI also is in support of providers being included in the Maryland Healthcare Cost Commission study. We believe that as providers, we have an important perspective that should be included in the study. Thank you very much for this opportunity to express MATSI's views.
And we thank you. Chair sees Delegate Cullison has a question.
Thank you, Mr. Chair, and I want to thank this panel, especially because I think what we're hearing is the benefits that telehealth, what we're hearing today and what we've been hearing over the last years, the benefits of telehealth. But I really want to make sure that all behavioral health practitioners understand that the law allows them to do audio only. And we've had a lot of discussion about that today, about how important it is. I recently became aware that the Board of Professional Counselors actually voted not to update their regulations and allow to reflect the law that audio only is permitted. And now there's a lot of confusion on the part of practitioners about whether or not they can provide audio only or communicate through asynchronous means. So I think, Anne, this might be you who has this background.
Absolutely. Thank you for the question, Delegate Cullison. That's accurate, that the board has actively refused to update their regulations. And as board members and staff for the board, they know the difference between statute and regulation, and that the statute supersedes. But the average everyday counselor can be extraordinarily confused by what to follow. And the absence of those clear regulations for practitioners to follow. A lot of folks they shouldn't have to, but there are some counselors who are hiring a lawyer to try to figure out what is it they're allowed to do. So we think it's just unnecessary confusion to what's clearly allowed under the Preserve Telehealth Access Act.
Mr. Chairman, I do one quick follow-up.
Quickly, thank you, sir.
Thank you. Do you have any indication for the rationale for this, for refusing to put this in the regs?
I believe part of it is because the Preserve Telehealth Access Act is time limited, it's sunsetted. I think they feel like after the study period, if things become more permanent or how things become permanent, then they'll go through that process. That is, I believe, at least part of the rationale for that.
Okay. Thank you very much. Thank you, Mr. Chair.
It hasn't stopped some other boards from updating their regs.
Okay, thanks.
We thank panelists. Our last panel is health insurance carriers, Matt Celentano and Allison Taylor.
Thank you, Mr. Chair and members of the HGO Committee. My name is Matt Celentano with the League of Life and Health Insurers of Maryland. Thank you very much for the opportunity to come and present to you a little bit today. A lot of what I was going to talk about has already been offered by the previous panelists. So I'll just hit some sort of high points from the carriers and then let Allison from Kaiser Permanente get to you on a little more of a granular carrier level. As you all know, the pandemic brought utilization that we've never seen before, and the carriers adjusted as quickly as they could. Although the carriers have been using telehealth as a service or a modality since 2014. So it wasn't really that new to carriers. The level of interest was certainly new. And we saw levels of utilization in telehealth that we've absolutely never seen before. And I think we'll probably never see again. March, April, May, and June of 2020, we were seeing upwards of 80 to 85% of all patient visits were being done by telehealth. I mean, I think a lot of that has to do with the fact that early in the pandemic, people were scared to leave their houses. I think a lot has changed since then as we've learned a lot about the virus, but that was levels that nobody could have ever expected. And we were able to handle the load of it. But it was going to be interesting as we move forward to see where the new normal becomes. As I said, utilization seriously backed off after that surge, back down to levels that we had seen, not as low as pre-pandemic, but certainly backed off to the 20% levels. There was a lot of desire by patients to go back to in-person. there were a lot of patients that really loved telehealth. There were also patients that felt more comfortable having an in-person visit. So that normalization and what the future is really, really interesting, and what we're looking forward to seeing. I do not have fourth quarter of 2021 numbers, and I'm sure that there was a pretty big uptick in utilization again as Omicron entered our lives, but it's not going to be anything compared to the spring and summer of 2020. I just guarantee. It's just not going to reach those levels again. That being said, we are going to normalize at a level that will be a percentage higher than we saw pre-pandemic. The question is, what will that new floor look like? With the uptick in utilization in telehealth in general, though, carriers are innovating. The market is going to sort of readjust for itself as it always does. And you have probably seen in the last couple of years or last couple of months, some carriers, some of which are operating in Maryland, are introducing telehealth only products. It is not surprising considering a big majority of younger folks and folks that live in the digital universe utilize this unlike anything else. And they want to operate on their phone. And there are a lot of people that want to buy a telehealth only product as their sort of form of primary care. There are going to be products that will continue to sort of innovate that market. We will see how that sort of plays out, but there are going to be new products coming forward all the time. We definitely appreciate Senate Bill 3 and House Bill 123 as an approach to sort of get it right as we move forward. And we're looking forward to seeing what the study with the MHCC looks like. One concern or thing we want to continue to talk about when we discussed the study last year during the discussions on the legislation, the way we wanted to look into the study was pre-pandemic, during the height of the pandemic, and post-pandemic. And I think that last spring, when we were all having these discussions, we thought that at this point we would be in a post-pandemic world. Well, with the continuation of surges and the virus not going away, as I think we were all hopeful it would, what is post-pandemic going to look like? And what is post-pandemic or continuing with pandemic telehealth usage going to look like? And that's something that all the carriers are super interested in trying to get a handle on. When we initially focused on preparing for this uptick in utilization, there was just the focus on the urgent. Well, now carriers are trying to sort of shift to look at how do we expand the use of telehealth to address chronic conditions. And we have to re-examine the role of telehealth to really approach social determinants of health and access and use of telehealth resources. And those are some of the questions that carriers are going to continue to grapple with. And we look forward to continuing to be a part of the study and what we can do more to make sure that more people are getting access to care. So with that, I will hand it off to my colleague, Allison.
All right. Thanks, Matt. Good afternoon. Committee members, thank you for having me today. My name is Allison Taylor, and I'm here today on behalf of Kaiser Permanente. We provide healthcare and health coverage to over 460,000 Marylanders. And I know I'm the last one to speak today, so I have 3 points that I want to make, and I'll try to keep it brief. So going to the first slide, I want to reinforce a point that Dr. Hasselfeld from Hopkins made, and that is how much patients are satisfied with telehealth offerings. He was pointing to the high level of satisfaction that Hopkins has seen through their system, through member surveys, that sort of thing. And Kaiser Permanente is seeing the exact same thing. The advisory board, this is their slide. They've done research on this nationally and seen, they have data on people's preferences for telehealth. Would you rather have telehealth appointment or wait 1 day, 1 week, 2 weeks to see an in-person appointment? And so what their research is showing is a huge shift between the data they have here in 2017 and this data in 2020. To look at just the first column here, in 2017, only 34% of people would have considered a telehealth appointment if they had to wait 1 day for an in-person appointment. By 2020, that had jumped up to 60%. Obviously, that's not everybody. There's still a range of consumer preferences out there, but I think is a pretty striking finding, and one that certainly bears true in our experience as well. All right, next slide. Second point I want to make is there was a lot of discussion last year about, is telehealth just an additive thing, or does it really replace an in-person visit? And how do we know that for sure? And how does, is it just additional care, or is it actually high quality care? So Kaiser Permanente has done some research on this topic that was published in the Journal of the American Medical Association in November. And what we found was that there was no difference in follow-up in-person appointments between patients seen in a video visit, a telephone visit, or an in-person visit. In all three of those settings, it resulted in a follow-up primary care visit about 25% of the time. So, I thought this was very interesting. It was kind of not what people were thinking. It is very, it was done in a very specific setting. It was only Kaiser Permanente patients in Northern California, and the patients being seen by telehealth were being seen by the exact same physicians that they would be seen in person. Those physicians had access to their full electronic medical record. Because it takes a long time to get studies published in a peer-reviewed way. This was all pre-pandemic that this study population was looked at, but I think provides some preliminary evidence that at least under some circumstances, telehealth can be just as effective as in-person care in preventing, in resolving patients' needs. And so overall being a more cost-effective way to provide healthcare. That's it. And then my third point on the next slide is to Matt's point about we're going to see some new healthcare products come on the market. And Kaiser Permanente has one called Virtual Forward, and I want to explain how it works. So it offers, so this one particular plan that we're selling offers patients unlimited telehealth appointments at no cost with Kaiser Permanente's primary and specialty care physicians. So no cost for telehealth for any physician that you would normally see in person at Kaiser Permanente. It also it covers some in-person primary care visits as well. This is just one offering of many offerings we have just for people who might be interested in this type of thing. And sort of as I was saying with our last study, the Kaiser Permanente physicians have access to the members' electronic health records. So, they have that full information when they're seeing them. So there is a room for a carrier to innovate in this space too. I appreciate Delegate Kaiser's shout out to us. Anyway, I look forward to any questions that you have.
Delegate Hill.
Thank you, Allison. Thanks for that. It's interesting. So you're offering this product that has unlimited tele with a single inpatient. Usually you're offering, companies offer things because they're going to see some savings. So what is it that you as a company, in addition to the fact that your patients are happy with it, what are you going to see by having fewer in-person visits? That mean you're going to have less staff, or because often telehealth can actually be more intense in terms of, what's required to produce it and do the records and all of that kind of stuff. So I'm just curious about why that benefits Kaiser.
Yeah, good question. And it's one of many offerings that we have, based on patient preference. We still have 34 medical facilities in this region. All of our providers practice out of those locations. And so if they're doing a telehealth appointment, it would be in the same facility that they're doing it now. We're trying, we'll see, maybe this is going to be super popular for folks going forward. And, maybe it's not, who knows, but we want to be an innovator in this space and try some new things.
So I guess my follow-up question is, well, again, so you want to be an innovator, if patient wants that's great, but what does the provider or Kaiser itself gain if patients decide they prefer are you talking about fewer facilities, or I'm just not clear where the savings?
No, not at all. And we're still expanding. In fact, later this month, we're opening a brand new state-of-the-art facility in Baltimore County. We opened one in Prince George's County earlier the year. So same brick and mortar footprint for us, just more modalities for our patients to be there. We're also opening something in Charles County, so in a couple of years. So we're continuing to expand to serve your patients. And we just opened one in Delegate Kelly's district a couple of months ago. So so we're moving in as much as we can.
Thank you. And we also welcome Delegate Kaiser to our committee. Now we know why she's here. Are there no further questions? If not, that concludes this hearing.
Delegate Rosenberg,
Yes,
may I interject
certainly.
here? It's been suggested that we move our hearing to 3 instead of 2:30 because some of the members are probably hungry. And I think we all do a better job if we're not being hangry. So we'll see you at 3 instead of at 2:30. Thank you all.
Thank you,
And now
Madam
you
Chair.
finish, Mr. Chair. Feel free to close the meeting in your own way.
I am one of those who is, I don't know if you said hungry or hangry, but I'm both. Okay. We will adjourn. We will have legislation dealing with this in the coming months, but this was very helpful briefing and an insight, and we will see each other again at 3 o'clock. We are adjourned. Thank you.